today's lecture is breech presentation. So basically this is a clinical sort of lecture. But we have to undergo certain terminologies before we start with the main objective. So the main objective of this lecture is that we should know certain terminologies, that is about the lie presentation. Then we'll come towards the incidence, the types of breech, what are the complications of breech delivery, and then how would you manage the breech delivery? What do you mean by term breech? What is the best mode of delivery for breech, and what is external cephalic version? And in the end, we'll talk about the breech vaginal delivery as well. So let's start with certain terminologies before actually coming towards the actual lecture. You should be knowing about what is lie, presentation, attitude, position, and station. I think this will be dealt in the ward as well, but let's have a brief discussion about it. Lie is simple relationship of longitudinal axis of fetus to longitudinal axis of mother. Presentation means the part which overlies the lower uterine segment or overlies the pelvic inlet. Attitude is the position of head with regard to fetal spine, either it is flexion or extension. Position, it is the relationship of denominator of fetal presenting part to fixed points of maternal pelvis. Like we take occiput, the relationship of occiput to maternal pelvis, whether it is occipital anterior or occipital posterior. Station is simply a measure of descent of fetal presenting part through the birth canal, whether the head is engaged or it is not engaged. So fetal lie, you can see this is the lie of the baby, that is the relationship of longitudinal axis of fetus to the longitudinal axis of mother. You can see this is longitudinal. The lie is longitudinal and the baby is presenting by cephalic. I don't know why it's not moving. Just hold. No problem. So these are the different positions you can see: fetal lie and presentation, right? Vertex presentation, breech presentation, face presentation, bra presentation, and the shoulder presentation. That is the part which is occupying the lower part of the uterus is called presentation. Look, see, it's so clear here. Cephalic presentation, the baby is presenting by head. And number 2 is breech presentation. The presenting part or the lower part of the uterus or the lower segment is occupied by the legs. Let's talk about the breech. The incidence of breech at term is 3%. 95% of the babies, the fetuses, they present with vertex, and the presentation also varies with the age. Like at 20 weeks of pregnancy, 40% of the baby will be in breech position. Later on, at 34 weeks, it is found that 6 to 8% is in breech presentation. And as the term approaches, term means 37 weeks onward, the baby takes a turn and only 3% of the fetuses are found to be with breech presentation. What are the etiological features? Why 3% of the babies remains in breech presentation? Most of these babies with breech presentation, they have special or any particular etiological factor. But in some cases, uterine anomaly means the uterus have some problem, some anomaly like bicondylic uterus, that may lead to a presentation of the baby in breech. Uterine fibroids. This is a tumors of the fibroid which may lead to baby to occupy a particular type of position, or if the placenta is in the lower segment, low-lying placenta, you can see a placenta previa. So if the lower segment is occupied by placenta, the baby may be in different position, because we know 90% or 95% of the baby present by CAF, cephalic presentation with the head. But in this case, sometimes the baby may not have that normal position. Polyhydramnios is the excessive presence of liquor around the baby. So that is polyhydramnios. In that case, the baby keeps on changing its position. So it may be unstable lie, it may be transverse lie, or it may be breech presentation. Oligohydramnios is opposite of that. The liquor becomes decreased due to some reasons. In that case, again, if the baby from the beginning is in breech position, the liquor decreases, so the baby will not be able to move and the baby will remain in breech position. Other causes of breech presentation is fetal anomaly. So always remember, when a baby is presenting by breech, rule out fetal anomalies, especially the structural abnormalities, by having a good ultrasound, spina bifida, that is neural tube defects, or sometimes the baby may be presenting by having hydrocaph, that is excessive amount of CSF in the brain and around the head, that is also known as hydrocaph baby. So anomaly scan is ideally done at 20 weeks of pregnancy, and these anomalies should be picked up, but sometimes may not be. So always think that breech a patient is having breech presentation, that we should always rule out anomaly of the baby. Then in cases of multiple or twin pregnancies, the baby may be presenting by breech. The first baby may be presenting by breech presentation. Coming towards the types of breech, there are three types of breech. Number one, which is the most common, is the extended breech. You can say here, other name is frank breech. That is, it all depends upon the flexion or extension at knee joint. So here you can see this is our flex at hip and extended at knee. So this is known as extended breech. 60 to 70% of breech presentation at term are extended breech. Here in this case, the chance of having cord taps is less as compared to the types of breech. Number two, flex or complete breech. You can see flexion at hip and knees, both are feet are present. You can feel the feet in the pelvis. So when you do examination here, along with the hip, you might feel the feeling of feet as well. Number three is incomplete. You can see one leg is flexed and other is extended at hip and knee, and buttocks are not in the pelvis. Instead, you can feel when you examine do the vaginal examination, you can feel only the leg of the baby. In this case, there is very less risk chance of having normal delivery, and there is a high risk of cord collapse in cases of incomplete breech. So these are the types. You can see the frank breech, complete breech, footling breech. Kneeling breech is less rare, but these are the three obvious types of breech. Excuse me. When we compare it to CAF. It may be to increase rate of congenital anomalies. 18% of the babies with breech presentation may be preterm, and we talked that 3 to 5% term breech presentation may have congenital anomalies. So always rule out anomalies in the baby before you decide for the mode of delivery. Odd accidents are more common in the breech presentation, especially in the premature breech, such as what happens as soon as the patient dilates and she's in breech presentation, the cord comes out of the vagina. So that is an emergency, especially in premature baby, the chance of having cord accidents or cord prolapse, cord presentation are more common. Or during delivery of the breech, there can be trauma to the baby. So these are the causes which may lead to increased morbidity and mortality in the breech presentation. So how would you diagnose? The important thing that whenever the patient comes to you in antenatal checkup, you have to do per abdominal examination. So in the per abdominal examination, you can see, or the patient will be telling you subcostal discomfort. She feels that something is hard on the upper part, some solid thing she feels at the upper part of the abdomen. So when you will do palpation of the patient, you will find that the solid pole is at the upper side, that the solid head ball-like thing is on the upper part of the fundus, and the lower part of the uterus is occupied by lower fetal pole, which is broader and is spread either within or above the pelvis. And also you will find that the fetal heart sound will also be on the upper part. And of course, for the confirmation, you have to go for the ultrasound. Although you suspect that there may be breech, but always have to confirm it by going for the ultrasound for presentation of the baby. So coming towards the term breech trial, the mode of delivery. Now, one thing is, number one was the etiological factors, how to diagnose, the confirmation is on ultrasound, and then the patient has come to you and she wants to discuss the mode of delivery. She wants to know which is the best mode of delivery. A term breech trial was carried out in many countries, in which Pakistan was also included. That was done almost, I think, 5 to 10 years back. Many countries participated in this term breech trial, and what they did, they compared planned cesarean delivery against planned vaginal delivery, and the conclusion of term breech trial was maternal morbidity and mortality was not different between the two groups. Term healthy breech fetus delivery is associated with reduced perinatal morbidity and serious neonatal morbidity. That is 67% reduction in perinatal mortality when the breech fetus is delivered by cesarean section. You can say the end results of the trial. So the best mode of delivery then later was recommended was cesarean section for the breech baby. But again, inadequate evidence to recommend mode of delivery for preterm breech. That is, for the term breech, it is recommended the best mode of delivery is cesarean section. But in preterm breech, again, there is some conflict because in our setup, preterm breech or preterm babies have got higher morbidity and mortality as compared to developed countries where the chance of having a baby at 28 weeks for survival is higher as compared to our setup because of the neonatal facilities, new ICU facilities, right? So this is still debatable. So that will depend upon the circumstances, depend upon the gestation age, that depend upon the weight of the baby, whether to decide for the mode of delivery for preterm breech. In a woman having breech presentation, always rule out if there is any underlying pathology, because if there is underlying pathology, cesarean section will not improve the neonatal or the long-term outcome. However, delivery as cephalic presentation or elective cesarean section reduces morbidity and mortality in most of the breech who have no abnormality as such. Regarding maternal risk of cesarean, emergency cesarean sections, what we know is the hemorrhage, hysterectomy, hematomas, infection, and DVT. This is overall emergency cesarean section I'm talking about. The fetal risk of breech vaginal delivery include intracranial hemorrhage, intraventricular hemorrhage, occipital diastasis, cervical spine injury, fracture of the femur, fracture of the humerus, because while you're delivering a baby, sometimes there may be excessive pressure on the femur, excessive pressure on the humerus while taking out the arms or the legs. So there is a risk of dislocation or the fracture of the long bones. Then brachial plexus injury, abdominal trauma like spleen and liver may be involved. Sometimes scrotal or labial trauma may occur, skeletal trauma may occur, or if you delay the delivery of the head of the baby, there can be an oxic injury to the baby as well. So mothers should always be counseled about these risks to facilitate decision making for the mode of delivery. So whenever a woman comes to you in antenatal clinic and at term she has breech presentation, you have to discuss her the mode of delivery and you have to tell her the pros and cons of cesarean section and the vaginal breech delivery, because we know the best mode of delivery for breech presentation is elective cesarean section as compared to vaginal birth. But if a woman insists on vaginal breech delivery, we cannot refuse her, but we have to make notes on the file that this is what the patient wants, and I have counseled her regarding the complications of breech vaginal delivery. I have counseled her the different types of problems which a breech baby can have during the vaginal birth, so that at least you are on the safer side. Cesarean section is not always a traumatic mode of delivery. In preterm breech delivery, difficulties in delivery are encountered even in the cesarean section, because there is a particular maneuvers by which you have to deliver a breech baby, whether it is cesarean or it is a vaginal breech delivery. Antenatal management. Suppose a woman, she's coming to you and she wants to have a normal vaginal delivery. So another way of conducting or converting the breech into calf is external cephalic volume. That is, by certain methods, by your hands, externally, by abdominally, you can convert breech to calf cephalic. But this cannot be done in all women, and there may be failure as well and certain disadvantages as well, and it has to be done after 36 weeks, almost at 37 weeks of pregnancy. There are certain contraindications of external cephalic volume, such as you should always rule out fetal anomalies, uterine anomalies. You should know the the location of placenta. If there is placenta previa, low-lying placenta, it should not be carried out. Or if a woman has a history of antepartum hemorrhage, then it is a contraindication. Relative contraindications include intrauterine growth restriction. If the baby weight is less than 2.5 centimeter or 2.5 kg, sorry, or it is more than 3.5, again it will be difficult, or due to some reason the baby has not been growing, maybe due to preeclampsia, then it should be avoided. Or the woman has previous history of any surgeries such as cesarean section or myomectomy, that is the removal of the fibroid, then it should not be carried out. Or if the woman has been suffering from preeclampsia, hypertension, then this is considered to be relative contraindication. What are the prerequisites of external cephalic volume? It should be done in a proper setting where the facilities of urgent cesarean section should be available in case of fetal compromise. That means when you are doing external cephalic version, you have the presence of ultrasound, you should have a CTG available, and you should have the access to the emergency cesarean section as well. Because when you are trying to rotate the baby, external cephalic version is that you are trying to rotate the baby to different position. So in that case, sometimes there may be some compromise to the baby, maybe fetal distress, maybe cord prolapse. Suppose, then you have to go for cesarean section immediately. So facility setting is very important. Then you should always look that the amniotic fluid is adequate. In case of oligohydramnias, it should not be carried out. It will not be successful. In case of polyhydramnias, again there will be difficulty. And before you do external cephalic version, CTG should be taken before and after completing the external cephalic version. The favorable factors which lead to success of external cephalic versions: number one, multiparity. That means a woman who has got many children. Flex breech, adequate liquor volume. That is, the liquor is amniotic fluid is adequate. Breech, which is mobile above the pelvic rim. If it is deeply engaged, then again you will have problem to disengage the breech. So success rate can be improved by placing the woman in frenulum position. Steps. Now let's talk about the steps. See, first of all, you have to disengage the breech from the pelvis, right? Little pressure has to be put. Whenever you are doing this, both hands should be used, and you have to exert a little bit pressure on the abdomen as well. So that might be a little discomfort to the woman. So you have to explain all these to the woman before you conduct for external cephalic version. So disengage breech from the pelvis, then forward somersault is done. See, you can see the forward somersault to move head to the lower pole. So you will disengage the breech and then try to move the head of the baby to the lower pole. Success rate is 60%. Again, this all depends upon your practices, how many patients you have been doing it, whether it's your practice or not. You are not doing this practice. But it is considered to be 60% success rate. In case the woman is Rh negative, that is her blood group is negative, anti-D should be considered. And after you complete the external cephalic version, CTG is done after the procedure. The complications of external cephalic version: cord compression. When you're rotating the baby, the cord may compress. Maybe the placenta may abruption can occur. That is mild dislocation or dislodgement of placenta may occur. Membranes get ruptured, or if there is non-reassuring fetal heart pattern on CTG, or you find something wrong on the CTG, then urgent cesarean section can be carried out in less than 1% of the cases. Now coming towards the breech vaginal delivery. Now what we have concluded from the term breech, that the best mode of delivery for breech is cesarean section. But sometimes the multigravida may come in emergency with active labor and she's presenting by breech, or some women would like to have breech vaginal delivery. So all the doctors who are working in ops or who are working in labor room, they should always have should know the different maneuvers to deliver a breech by vaginal route. So some women may present in advanced labor or may decline cesarean section. So always, if a woman decline, you should always make a note. It should be mentioned on the notes that the woman wants this and she's agreed with the complications which can occur during the breech vaginal delivery. Or sometimes unbooked patients may come, especially in CHA, unbooked patients, they come to the labor room. They sometimes what happens, they deliver, the breech is delivered at home and the head is stuck. This type of woman is also coming in our labor room, or sometimes they come in advanced labor. So then you have to decide whether at this stage of advanced labor you have to go for breech vaginal delivery or you have to take her to cesarean section. So all the procedures have some prerequisites. Remember, Appropriate selection of patient. Suppose a woman wants to have normal breech vaginal delivery, you have to select. The setup should be double setup. Operating theatre should be backup. That means you should have a theatre available as well, where you are conducting a breech vaginal delivery. The theatre facilities should be available. Frank and complete breech presentation, but more successful breech vaginal deliveries with the extended breech delivery. Clinical, the size of the pelvis assessment should be done that the pelvis is adequate. There should be spontaneous onset of labor. We try to avoid going for the induction of labor in breech. Normally, they have spontaneous onset of labor. And the estimated fetal weight should be less than 3.5 grams if the baby is good size, or you can say the macrosomic baby is still good size, then try to avoid going for the breech delivery, because in this case the baby's buttocks or the legs may come out, but you may have problem in delivering the head. Successful outcome depends on normal rate of dilatation, descent of breech, and the fetal heart sound. Epidural analgesia provides good relief for good maternal cooperation, but epidural analgesia is not available in most of the hospitals in underdeveloped countries. And mother should be encouraged to bear down only when breech has perineal phase of second stage. Tell mother not to push, because many times as soon the labor starts, the mother starts pushing. So that is a wrong practice. They should only bear down when the breech has reached the perineal portion. So let's talk about the breech vaginal delivery, the different maneuvers. It's written very nicely in the 10 teacher, very nicely. So whenever you find the breech patient has a breech presentation and she's dilating, all is well. So you check the estimated fetal weight is around less than 3.5, and breech is presenting by extended breech, and breech has engaged in the pelvis. So let the breech descend spontaneously. You are not going to do anything. Let the labor go smoothly with the CTT on your side, and it should. You will not do anything till the buttocks distend the perineum. Encourage unassisted delivery beyond the level of umbilicus. Assistance is only by lateral manipulation. That means hands off from the breech. You're not going to pull the legs. You're not going to pull the buttocks. Just sit there and let the breech come out by itself, the buttocks. But you can give them support as well. So, and if you find that the patient needs episiotomy, yes, we can give local anesthesia and episiotomy can be carried out. With frank breech, delivery of the legs is carried out by the Pinard's maneuver. That means once the buttocks are delivered, you just help the buttocks, and with the help of your finger, slight abduction at hip and flexion at knee, you can deliver the legs one by one, which is known as Pinard's maneuver. Hold fetus by placing hand on the side. Both of your hands should be placed on the fetal pelvis gently, either with the help of some cloth, and so that you can simply try to hold it properly and let it come by itself. And if you will not pull it, you will not going to pull it. If the umbilicus is there, you can gently release the pressure of the umbilicus, and the fetal bag should always be empty. Always remember, this is very important, because if the fetal bag is not interior, what will happen? The baby will come with the head or towards the pubis, that is face to pube. So that will never be flexed. It will never be possible for you to flex that head. So be careful that the fetal dorsum, the back of the baby, is always interior. With flexed arm, then slightly keep traction on the abdomen with both the hands, and with the pains the patient will push, and you will find that the scapula will be visible gradually. And when the scapula is visible, you will deliver the shoulder by sweeping in front of the fetal chest. See, these are the different pictures you can see. right? With the both hands, we are holding the baby, umbilicus is released, and then with the extended arms, scapula not visible, arms, if in case of arms are high in the pelvis, then you have to do the lockset maneuver, that you will gently try to locate the hand and then gently make it flex and then remove it, take it out, right? Posterior shoulder is brought anteriorly by turning the baby clockwise. Deliver the shoulder, and after delivering the shoulder, the next is the baby has to turn anti-clockwise to encourage descent of the other shoulder. After delivery of the shoulder, fetal back should be anterior with the chin facing the sacrum and occiput behind the pubic symphysis. Look here. This is the delivery of the head. The delivery of the head can be done by forceps or by Marusis simulate maneuver. This is the Marusis simulate maneuver. One hand is just behind the at the level of the neck or occiput, which is pressing the occiput to make it flexed, and then the other hand is pressing the side of the lips. You can say the mandible to make it flex, and the only way to do this is that we want to flex the head, because the diameter of the flex head is the least as compared to other 9.6. I just told you that in case, look here, the back of the baby is anterior. In case the back is upside down, that it is posterior and baby is facing by face to pube, you will never be able to flex the head of the baby, and that is the problem. When that is why the home deliveries, the baby gets stuck with the head because they are unable to manipulate the head of the baby. So delivery of the fetal head is sometimes problem in case of breech. That is, breech delivers, but the head gets stuck. So you can deliver with the help of forceps, or you can do the Marusis simulate maneuver. Look here. One of the person will be holding, the assistant will be holding the legs, and you will apply the forceps and then gently press the take out the baby. Remember, the breech in the breech baby, there will not be any molding. Molding is also important in cases of delivery, because when the baby is presenting by cap, the skull bones, they are movable, so there is always a molding. So molding helps in delivering the baby by vaginal delivery. But in case of breech delivery, the head is above, so there is no molding. So that is why there may be sometimes problem in delivery, and you have to be very gentle. Never go fast in breech delivery, because in case you deliver the breech fast, sometimes that can lead to intraventricular hemorrhage, or you can go for the fractures as well. So this is the delivery of the baby by forceps. The key points. Now coming towards the key points. Breech presentation is associated with high perinatal morbidity and mortality, and serious neonatal morbidities such as fractures and dislocations, fracture, breakage, bruxes, injuries. The breech presentation always rule out anomaly of the baby and placental localization if it is low-lying or it is not. For term healthy breech, delivery as cephalic presentation by external cephalic versions. That means if you are expert enough in doing external cephalic version, that should be offered to the patient at 37 weeks of pregnancy, or planned cesarean section should be carried out to reduce the perinatal morbidity, mortality, and neonatal morbidity. External cephalic version should be offered around 37 weeks onward, not before that. For breech vaginal delivery, appropriate case selection and experienced personnel are important. Breech vaginal delivery may be required in patients presenting in advanced labor with breech. I just discussed with you that many patients at CHK, they sometimes present with advanced labor, breech presentation and advanced labor. So in that case, you can carry out breech vaginal delivery, but experienced personnel should be important, should be there to carry out the different maneuvers. So thank you so much. for your presence. And if you have any questions, so we can take up the questions. Position, what do you want to know about the position? You know, these are the terminologies: lie, presenting part, and the position. Position may be either it is occipital anterior position or occipital posterior position. So I think this will be better. You will practically, if you see the position, then you will understand better the position.
जी मैडम।
जी क्वेश्चंस लेने?
नहीं मैडम, अभी तो बस वही था एक जो आपने दिया और
चलिए 2 मिनट वेट कर लेते।
जी मैडम।
When the head is stuck and the patient presents with advanced labor, what we do is we give episiotomy and try to make the baby's head flex, the maneuver which we discussed. Either you apply forceps or you do the Maristes method. Because if a doctor is experienced enough and they know the procedure, even the staff and the postgraduates, they can deliver the baby by giving episiotomy, by applying forceps and deliver the head, or by Maristes maneuver, that is making the head flex. So that helps in delivering the baby. Breech extraction is not the correct word for breech vaginal delivery. Breech extraction is only done in cases of twin pregnancy. So if the first baby is presenting by calf and the other baby is presenting by legs, then you try to find out the legs and take out the breech. That is known as breech extraction. And breech vaginal delivery means the baby is presenting by breech and you deliver the baby by vaginal route. This is different. Fetal bag, no, most of the time it is anterior, the fetal bag, but if it is not anterior in the beginning, you make it anterior. You rotate with the both hands when you're holding the buttocks of the baby, you rotate it. You can rotate it to anterior. If it is not anterior and it is posterior, remember the head of the baby will not be delivered. So you have to make it anterior. Baby can move from posterior to anterior easily by the abdominal. What 3 maneuvers? The 3 maneuvers are very nicely written in teacher, right? That when you are going to conduct a breech vaginal delivery, first of all, there will be delivery of the buttocks and the legs. Number 2, delivery of the abdomen, and then the shoulders and head. One by one you have to. You are not going to pull the buttocks, which is simply hold the buttocks, give support, and where you think that the episiotomy is required, episiotomy should be done, and then the buttocks comes out by itself. Just help the legs to come out, then hold the breech, the buttocks and the abdomen with both of your hands, and with the pressure or with the pressure, the patient will push the baby more, and the baby will descend by itself. When you identify the scapula, try to find out where are the hands, and then by the help of gently putting your finger inside the axilla, you can remove the hands one by one, anterior and the posterior, and then the head will come. So for the head, you have to keep the baby in the lower position, that the back of the baby should be interior, and then you see whether you can deliver the baby by forceps or by the Maris's Semmelweis method. It's very nicely written in 10th feature. Yes, cephalic we say when you do examination for abdomen. When you do vaginal examination, then you will usually use the word vortex. Cephalic means whole of the head of the baby. Vortex is the particular area bounded by anterior and posterior and the parietal eminences, which is means identified on vaginal examination. So it is different. The cord accident, then of course that is a real emergency. First of all, then you have to see whether the pulsation is there in the cord or not. If the pulsation is not there, or if a longer time has elapsed from the cord until the patient comes to your ER, then babies, if there's no heart sound, then of course try to deliver the baby by vaginal route. But if the cord pulsation is there, then you have, it's an emergency, and then you have to go for cesarean section. With before that, explain everything to the attendant that this some accident or emergency has occurred. We will try to rescue the baby by doing cesarean section, but sometimes there may be, by the time you arrange for the cesarean section, you take the patient shift to the there, then there may be absence of fetal heart sound.